A very good morning to all of you, and I am thankful to Dr. Sinha for giving me this opportunity. I will be speaking on recognizing endophthalmitis with slit lamp and with B-scan, the two basic tools that we have with us. So, to define endophthalmitis, this is an inflammatory condition of the intraocular cavities, and it is usually caused by infection. But it could also be non-infectious, that is the sterile endophthalmitis, which may result from various causes, such as the retained native lens material after an operation or from toxic agents. Panophthalmitis, it is the inflammation of all the coats of the eye, including the intraocular structures. So, in most of our clinical series, gram-positive organisms are the most common causative organisms of endophthalmitis. The most common organisms are coagulase negative staph epidermidis, Staph aureus, and Streptococcus species. But we also have the gram-negative varieties like the Pseudomonas, the E. coli, and the Enterococcus. So, going into the pathophysiology, normally the blood-ocular barrier prevents invasion from infective organisms. But if this is breached, which is directly through trauma or indirectly due to change in permeability, secondary to inflammation, infection can occur. Endophthalmitis could be associated with surgery. It could be acute, delayed post-operative, or bleb-associated. It could be traumatic, which again could be bacterial or fungal. It could be endogenous, or it could be associated with corneal infection. Here we will restrict ourselves with the post-operative endophthalmitis. So, the endophthalmitis associated with surgery could present at different times. It could be an acute post-operative endophthalmitis, which is defined as this arises 1 to several days after the surgery. There is a sudden decrease of vision and increasing eye pain. So, any patient after surgery complains of these symptoms, you have to take them very seriously. So, what are the signs that we look for? Without the slit lamp, you may see lid edema, intense conjunctival injection and chemosis, and you may spot a hypopion, which is a pus-like in the anterior chamber. Looks like a white fluid, and of course, the red reflex will be decreased because of the subsequent vitritis. Slit lamp examination will reveal severe inflammation in the anterior chamber and in the vitreous. So, going into delayed post-operative endophthalmitis, this develops a week to a month or more after surgery. It may take even years to develop, but the average is 9 months. There is an insidious decrease of vision and gradually increasing redness with minimal or no pain. What are the signs? Without the slit lamp, we look for conjunctival injection, hypopion. The pupillary margin will be clumped, the cornea will look cloudy due to edema, and these signs are clearly seen with the slit lamp, as are the anterior chamber and vitreous inflammatory reactions. Bleb-associated endophthalmitis, when drug therapy fails, we go in for bleb surgery or trab surgery. A trabeculectomy is a procedure that creates a fistula which allows aqueous to drain from the anterior chamber. A so-called bleb is formed over this area, seen as a smooth raised patch just above the cornea. Occasionally, this may get infected when we call it blebitis, but when the subsequent vitreous is also involved, then we call it bleb-associated endophthalmitis. How does the patient present? There is a short history of rapidly worsening vision and pain, with a lot of redness, especially in the bleb area. The bleb will also appear very cloudy, translucent, milky white, and there may also be a hypopion. So, this is a picture of a bleb-associated endophthalmitis. You can see that the bleb is totally white, milky. There is a subsequent corneal edema, steamy cornea. So, putting all this in a tabular form, the fulminant, always remember, it will present less than 4 days, and an acute will be between 5 to 7 days. Fulminant, these are the causative organisms, gram-negative bacteria, Streptococcus, Staph aureus. Acute would be Staph epidermidis, coagulase negative cocci or fungus. Chronic, which presents more than 4 weeks, is again delayed entry, that is bleb related, or delayed onset. The most common of that is the P. acne. Going into the causative organisms wise, the bacterial endophthalmitis usually presents acutely with pain, redness, slit swelling. All this I have already discussed earlier. Fungal endophthalmitis has a more indolent course over days or weeks, and symptoms are often blurred vision, pain, and decreased visual acuity. And obviously, we have to ask for a history of penetrating injury, especially with a plant substance. Post-surgical, I have already mentioned in my previous slide. So again, going into the symptoms in a tabular form, We have the patient will complain of vision loss, which is the most common symptom, eye pain and irritation, photophobia, headache. There will be ocular discharge, and along with conjunctival congestion. So, what are the signs that we look for? The eyelid swelling, erythema, injected conjunctiva and sclera, the hypopion, subsequent vitritis, chemosis, reduced or absent red reflex, papillitis, cottonwool spots, or corneal edema and infection. You can see in the slides which are alongside. The first slide on the top shows this intense fibrinous reaction in the anterior chamber. Corneal edema is also present. In the bottom slide, you can see that at the level of entry there is a lot of edema, corneal infiltrates, and subsequent hypopion and period. So the endophthalmitis vitrectomy study had different grades to grade endophthalmitis depending on visibility. Grade 1 was most of the retina could be seen. Vision was about 20/40, 6/12. Grade 2, the second order retinal vessels were visible. Grade 3, some vessels are visible but not the second order. Grade 4, you can see no retinal vessels. And grade 5, then there is no red reflex. These are some pictures which illustrate the endophthalmitis. So going on to the ophthalmological evaluation, first we check for visual acuity, which is the most primary thing that we do. We have to examine both the eyes by slit lamp biomicroscopy, check the intraocular pressure. A dilated fundoscopy is very important to see the retinal details and the red reflex. And an ultrasonography now has become mandatory if the fundus is not well visualized. So this will help to determine if a retained intraocular foreign body is also present, the density of vitritis, and if the retina is attached or not. Routine cultures include aerobic, anaerobic, and fungal cultures. This is the most important slide of my presentation, and one must always take this take-home message. Any unexpected inflammation following intraocular surgery has to be considered as endophthalmitis unless proven otherwise, and treatment has to be constituted very, very aggressively. Again, going to ultrasonography, now it has become mandatory. It is useful aid in planning diagnosis and planning the surgery, vitrectomy surgery. It is helpful when positive findings are seen, such as low amplitude mobile echoes, vitreous membranes, and then there is thickening of the retina and the choroid. However, sensitivity is not high enough to rule out the diagnosis with a negative ultrasound. So these are some pictures of the ultrasound. You can see these low to medium reflective echoes in the vitreous cavity, especially the posterior vitreous cavity, which are mobile. This is another picture. So there are other various conditions that can mimic endophthalmitis. Going into surgical conditions, if there is a lot of fibrinous reaction post VR surgery, then it can mimic endophthalmitis. You can see a lot of these fibrils in the anterior chamber. The vitreous may also not be very well seen. The retina may appear a little hazy. Dislocated lens or nucleus, a chemical response, a complicated VR surgery which takes so long, a lot of manipulation, and a microscopic hypema. Non-surgical could be a retained intraocular foreign body, severe pars planitis, an old vitreous hemorrhage, or toxoplasma retinochoroiditis. So this will be dealt by the subsequent speaker, but just 2 slides on this. Aqueous tap, it is obtained using paracentesis using a 25 to 27 gauge needle. 0.1 ml of fluid is withdrawn in a controlled manner. Aspirate has to be sent for gram, Giemsa culture. A possibility of circulating organisms in an aqueous tap is 36 to 40%. But the vitreous biopsy is more definitive. It is obtained using a 23 or 22 gauge needle through a plas plana before injecting the intravitreal antibiotics. It is always wise to first obtain an undiluted specimen with the help of vitrectomy cutter and gentle suction. A cutter is important because otherwise we create a lot of traction on the vitreous membranes, and subsequent risk of RD is increased. Then after obtaining the specimen, the infusion can be started and vitrectomy can be continued. Thank you for your patient hearing.
Thank you, Dr. Pooja.